Hello, my dear students. Welcome on the new session. We are in pharmacology, we are in endocrines, and this session is about sex hormones. So we have to deal with the estrogens, progestins, androgens, so on and so forth. So let's see how much we complete on this session. So we begin with estrogens, and for your knowledge, estrogen receptors are alpha type of estrogen receptors which are present in the female sex organ breast. These are important organs, and the third one is pituitary. They are also present in the hormone responsive breast carcinoma cells, and they are present in the hypothalamus. Beta receptors, beta estrogen receptors, beta B for bone. Don't forget the bone, that's very important site. It's also present in the male prostate, then it's present in the ovaries, it's present in the liver, blood vessels, heart and central nervous system. Estrogen receptor is a nuclear receptor. Once again, it's like a steroid receptor, undergoes dimerization, and then there's a combination or activation of the estrogen response elements called ERE that leads to gene transcription promoted through agonist act through the co-activator proteins and antagonist act through co-repressor proteins. Endogenous estrogens are estriol, estrone and estradiol, and they come from ovary, that's Graafian follicle, they come from corpus luteum and from placenta. All of them, the endogenous ones, they are orally inactive, they are short acting, and there's rapid hepatic metabolism. So no question of the endogenous estrogen to be used exogenously by oral route of administration. Synthetic estrogens, steroidal, example is ethinyl estradiol, mestanol, tibolone and quinestrol. And non-steroidal, diethylstilbestrol, hexastrol and dienestrol. Ethinyl estradiol, 30 to 50 micrograms is the dose for contraception. The transdermal patch can be used, one patch per week for 3 weeks and the free period for 1 week. Vaginal ring can be estrogen plus progestin and it acts for 3 weeks. Dienestrol is available as topical vaginal application. Tibolone is a 19 non-steroid compound and is available as hormone replacement therapy in the form of estrogen plus progestin. Estradiol is available as transdermal therapeutic system TTS in the form of a patch. Estradiol is also available by intramuscular injection, and this can be used in carcinoma prostate. And finally, there is an estrogen called mestanol. Let's go for the actions of estrogen, and probably you have done them in your physiology. Female reproductive system growth, development, puberty, menstrual cycle, sensitizing the uterus to the action of oxytocin. Then the secondary sex organ development, the characteristic development and the behavior. Next, estrogens have anabolic effects. And let me remind you about the bone. Fusion of epiphysis, modifying the regulatory cytokine signals from osteoblasts, maintaining the bone mass, inhibiting osteoclast pit formation, stimulating the clast apoptosis, and inhibiting the bone resorption. So, there's increased bone matrix proteins, namely osteonectin and calcin, and they increase the collagen and alkaline phosphatase. Estrogens lead to positive calcium balance. They stimulate the renal hydroxylase to form the active form of vitamin D3. The next action of estrogen, important one, is salt and water retention. This can lead to edema and a slow rise in blood pressure. Then there could be carbohydrate intolerance, hyperglycemia and insulin resistance. They can of course precipitate diabetes, but the dose in oral contraceptive pills and HRT, that's hormone replacement therapy, is a low dose and the effect is less. Please mind well, HRT dose is less than the contraception. Next important action of estrogens is on cholesterols. They decrease the LDL and they increase the TGs and increase the HDL. They also lead to increased coagulability and they induce the synthesis of factors 2, 7, 9, 10. They also decrease the antithrombin 3 and they induce the nitric oxide and produce vasodilation. So there's increased cholesterol in bile, decreased bile salts, so they are lithogenic. Now we come to the adverse effects of estrogens. First adverse effect, nausea, epigastric distress and migraine. This is very common. Next, breast tenderness and engorgement. And the third one, very important, you have heard the actions, they stimulate the blood coagulation. This decrease antithrombin 3, increase in the factors 2, 7, 9, 10, and this makes them susceptible to produce thromboembolic events, especially the deep vein thrombosis. They produce fluid retention, peripheral edema, hypertension, cerebral thrombosis, coronary thrombosis, and MI. There is more prevalence with the use of estrogens. Estrogens are lithogenic. They can produce cholestatic jaundice, they can produce gallstones, gallbladder disease, and benign hepatomas. They are known with estrogens. Next important adverse effect of estrogen is carcinogenicity. That's carcinoma endometrium. There could be endometrial hyperplasia and irregular bleeding and dysfunctional uterine bleeding, especially if they are used during the menopause. And there's a rare adverse effect which is happening in the offsprings of the mothers taking estrogen, especially diethylstilbestrol, and it leads in the offsprings to vaginal carcinoma, infertility, ectopic pregnancies, and premature labor. Some other adverse effects include, if they are used during pregnancy, there could be vaginal and cervix carcinoma in the female offspring, as we just said, and other genital abnormalities, especially with diethylstilbestrol. Given to males, there will be gynecomastia, loss of libido, and feminization. And given to children, it will be early epiphyseal fusion and stunting of growth. Please mind well, the inducer drugs, they decrease the effect of estrogen, inducers of the CP450 enzyme system. And just a reminder for you, barbiturates, carbamazepine, and phenytoin, all related to epilepsy, then griseofulvin, an antifungal drug, and rifampin, an anti-tuberculosis agent. So you need to take care if the woman has diseases which are related to these particular drugs and she is receiving estrogens, then you'll have to think about modifying the method of contraception or sometimes modifying the therapy for that particular disease. Let's come to the uses of estrogens. They are used as hormone replacement therapy in the menopausal syndrome. So they take care of the hot flashes, the vaginal atrophy, osteoporosis, and the emotional changes. So they are beneficial for all these things. Number one, hot flashes improve, vaginal atrophy improves, osteoporosis, they're useful, and emotional changes. Female hypogonadism and delayed puberty are next indications. And then contraception, they are used as oral pills with progestin. Other uses of estrogen are going to be discussed now. Before this, as far as the menopausal syndrome or as far as the HRT is concerned, we must remember HRT is not a routine process. We need to use smallest doses for shortest duration. It's useful, but it's not best for osteoporosis, and there are better options for osteoporosis. And please mind well, they increase the risk of thromboembolism, MI, stroke. This particular issue is not resolved, although the other four things, estrogens are beneficial. So they are also used for senile atrophic vaginitis and craurosis volvi. They are useful to treat hirsutism, amenorrhea, dysmenorrhea, and acne, and they are useful as palliatives in the prostate cancer. So these are some uses of estrogen. Now we come to discuss the drugs acting on the estrogen receptors, and a very popular group is selective estrogen receptor modulator, and it's a high yield thing for your examination. You need to know what are the selective estrogen receptor modulators. Why we are not calling them the estrogen receptor agonist and antagonist? Because they have mixed action on various types of estrogen receptors. So we call them selective estrogen receptor modulators. The first important substance is clomiphene citrate, which is used as an ovulation inducing agent. Please understand the mechanism of action of clomiphene. How does it act? Clomiphene selectively blocks the estrogen receptors in pituitary. And when they block the estrogen, it blocks the estrogen receptor in the pituitary. There is inhibition of negative feedback. You know, for all trophic hormones, a negative feedback exists, and this estrogen receptor in the pituitary will be taking part in the negative feedback, and clomiphene inhibits the negative feedback. When this negative so it's a blocker of pituitary estrogen receptor. When there is inhibition of the negative feedback, it leads to increase in the FSH and LH. So it increases the gonadotropins, and this induces ovulation and pregnancy. So that's a useful ovulation inducing agent. It's used for induction of ovulation in the women with anovulatory cycles. The usual mode of treatment is 50 milligrams every day for 5 days, starting at the 5th day of the menstrual cycle. In males, clomiphene can be used to treat oligozoospermia. So that's about clomiphene citrate. The next two drugs, selective estrogen receptor modulators, are tamoxifen and tormephene. And tamoxifen especially is useful in advanced or metastatic estrogen receptor positive carcinoma breast, because they are modifying the estrogen receptor. 10 to 20 milligrams 2 times a day is the usual dose. And what's the action of tamoxifen? It's antagonist at breast estrogen receptors. So if the carcinoma is estrogen receptor positive, you're going to get a better response to tamoxifen, and tamoxifen is preferred to treat the ER positive carcinoma breast, which is advanced or metastatic. Now please remember, it's agonist at the bone receptors. So this is good, this is not harmful, but it acts as partial agonist also in the endometrium. And because it's an agonist at the endometrium, there is an increased risk of endometrial hyperplasia and endometrial cancers. The next use of tamoxifen, tormephene is in male infertility. The next selective estrogen receptor modulator is raloxifene. And raloxifene is little different than tamoxifen. Look at it. It is agonist at bone and antagonist at breast. So that's the same like tamoxifen, but it has no effect on endometrium. It does not do anything to the estrogen receptors in the endometrium. It doesn't stimulate, it doesn't block, and this drug does not have the risk of endometrial carcinoma or endometrial hyperplasia, and it is proven to be efficacious as agonist at bone. So raloxifene is useful for postmenopausal osteoporosis. So tamoxifen, carcinoma breast, and raloxifene, postmenopausal osteoporosis. It's been found to decrease the bone resorption, the turnover. It's been found to decrease the vertebral fractures, and it increases the bone density. We have the next drug, which is an anti-estrogen. We call this drug as anti-estrogen, but it is not an SERM or selective estrogen receptor modulator. The name of the drug is anastrozole, and it inhibits the enzyme aromatase, which is involved in the synthesis of estrogen. So it is an anti-estrogen. It doesn't block the estrogen receptors, but it inhibits the synthesis of estrogen receptors. And again, this drug, anastrozole, is useful in estrogen-dependent postmenopausal breast cancer. So this was about the selective estrogen receptor modulators and one drug which inhibits the estrogen synthesis. So this is a brief overview of estrogens. Now we are going to discuss the progestins. Pro is standing for something. Gestation is pregnancy. So these are the hormones which are going to favor the pregnancy. So the next 6 hormones are progestins. Progestins are secreted by the corpus luteum, by the placenta, also by the testes and the adrenal cortex. And they are secreted from the corpus luteum, placenta, in males from the testes, and as we already said, both sexes from the adrenal cortex. Receptors for progestin are present in the female genital tract, breast, central nervous system, and pituitary. This is again a nuclear receptor. The process is same like a steroid receptor, dimerization, and then activating the progestin response element, leading to synthesis of the co-activator proteins. Progestins do certain peculiar actions. The action is preparation for nidation, that is embedding of an early embryo in the uterine endometrium, and maintenance of pregnancy. The progestins, they maintain the post-ovulatory secretory phase of endometrium, assuming that fertilization might have occurred. So that's great. It prevents the shedding, decreases the motility, and inhibits the fetus rejection. So this is how it works, and it's helpful in maintenance of pregnancy. In the uterus, it produces secretory changes, hyperemia, tortuosity of the glands, and increase the secretions. And they will decrease the epithelial proliferation. Cervix, the secretions will become viscid, scanty, and it will make the medium hostile to sperm penetration. Lack of progestins leads to bleeding. So as soon as the progestin level comes down, that's a stimulus, that's a trigger for the menstrual bleeding. If there's pregnancy, there's continued action of the progestin, and that is responsible for the decidual changes in the endometrium. As far as breast is concerned, there's acini proliferation in the luteal phase, and there's preparation for lactation. After the pregnancy, that's after the childbirth, there is an all of a sudden withdrawal of progestins that leads to prolactin release, and this is the stimulus for milk secretion. In the CNS, they produce sedation, they produce a rise in the temperature. That's why there is raised body temperature heat production in the luteal phase. And metabolism, they impair the glucose tolerance. There are some progestins which are androgenic, and the androgenic progestins, they increase the LDL and they decrease the HDL, and this is on the contrary of the estrogen effect. Estrogens have beneficial effects, as we saw, as far as the cholesterol is concerned. They decrease the LDL, but some androgenic progestins, they raise the LDL and they decrease the HDL. Let's see the adverse effects of progestins. Headache is a predominant adverse effect, and mood changes in the form of depression. When you use them continuously, especially if it is an androgenic progestin, it leads to sodium and water retention, weight gain, hirsutism and acne, and skin pigmentation. It also decreases the libido, and as we already said, there is decreased HDL and increased LDL, so there is increased LDL-HDL ratio. This effect is seen less with a substance, with a drug called desogestrel. This is a new substance. Next adverse effect is glucose intolerance, so we call them diabetogenic hormones. The other adverse effects include the engorgement of the breast and pain in the breast, that's mastalgia, increase in the body temperature, edema, esophageal reflux, mood swings, and irregular bleeding. That's the problem. Irregular bleeding and sometimes amenorrhea. And there is an increased risk of breast cancer with the help of progestins. As far as the progestins are concerned, important progestins are progesterone, hydroxyprogesterone caproate, and medroxyprogesterone acetate. And there are 19 nortestosterone derivatives. They are more important. That's norethisterone, norgestrel, levonorgestrel, a very important compound. And just now we were saying a beneficial compound as far as the lipids are concerned is desogestrel, plus you have norgestimate, gestodine, and drospirenone. Desogestrel has got minimal androgenic and anti-estrogenic activities are common to all others. So desogestrel has got the same anti-estrogenic type of activities, but the androgenic activity is minimal. Uses of progestins will be obviously for contraception by oral route of administration in combination with the estrogens. For depot contraception intramuscularly, I just now told you some names, so I'm picking up the name from that. That's MPA, medroxyprogesterone acetate. And one intramuscular injection acts for 3 months, and some drugs are also available as patches and implants. Then progestins are useful in the hormone replacement therapy, HRT, with estrogens. Why? Because estrogens have an increased risk of endometrial cancer. If you add progestins, the risk of endometrial cancer is minimized. But mind well, although the risk of endometrial cancer is less, but progestins increase the risk for carcinoma breast. Progestins are useful to manage the dysfunctional uterine bleeding. Norethistérone can control the bleeding and can assure prompt bleeding on withdrawal. To suppress the ovarian function, progestins can be used in conditions like dysmenorrhea and endometriosis. The next use is postponing the menstruation. And as we said, the progestin is going to take granted that at the time of ovulation, around the ovulation, there is fertilization. So it's going to protect. If there is fertilization, it's going to protect. It's progestin. It's in favor of pregnancy. So you can postpone the menstruation as long as there's good progestin level. The menstrual blood flow is not going to start. The compound is norethistérone, 5 to 10 milligrams every day by oral route, or hydroxyprogesterone caproate, 250 milligrams by intramuscular route. This can postpone the menstruation. And as far as oral norethistérone is concerned, when you stop the drug, within a period of 2 to 3 days, the menstrual flow will start. Progestins are useful as palliative drugs in the endometrial carcinoma. We went through the actions and the effects of the progestins. Why progestins are important? They are combined with estrogens to decrease the risk of dysfunctional uterine bleeding and endometriosis. They decrease the risk of endometrial cancer and endometrial hyperplasia. It's important that the older progestin can block the beneficial effects of estrogen on LDL and HDL. Just now we saw it. Then the next important thing is progestins mainly suppress the luteinizing hormone, that's LH. So progestins alone are able to inhibit the ovulation. So sometimes you can use progestin alone as a contraceptive. Next, addition of progestin to the estrogen component increases the risk of breast carcinoma and decreases the risk of endometrial cancer. So I have written some 4 very important facts on this particular slide and we discussed it. Now let's go to see what are the differences in the synthetic progestins. There can be progesterone derivatives which are pure progestins. You can follow the slide. And there are nortestosterone derivatives which have got additional weak estrogenic activity. They have weak or no androgenic activity and they are weak anabolic substances. Once again, progesterone derivatives are pure progestins, whereas 19 nortestosterone derivatives, they have additional weak estrogenic property, weak or no androgenic property and weak anabolic property. Next difference is with progesterone derivatives, there is weaker anti-ovulatory effect and these drugs are mainly used as adjuvants in hormone replacement therapy. Coming to the other side, this 19 nortestosterone derivatives is interesting that they have got potent anti-ovulatory effects and the less dose of estrogen can be given because of this. And this is why these 19 nortestosterone derivatives are preferred and they are used primarily in the oral contraceptive pills. If there is 13-ethyl substitution in the structure, that for example in the drugs like norgestrel and levonorgestrel, these drugs become more potent. Their potency increases by the 13-ethyl substitution. Continuing with the differences in the next slide, examples, the older progesterone derivatives are hydroxyprogesterone caproate HPC, medroxyprogesterone acetate and megestrol. And the newer one, the newer progesterone derivative is normegestrol acetate. Let's come to the other side to know the names well. Amongst the 19 nortestosterone derivatives, the older one is norethistérone, about which just now we said for the postponement of menstruation. And along with that there is linestrenol and levonorgestrel. And in the newer ones are called as gonans and they are desogestrel, norgestimate and gestodine. Once again a reminder, the newer ones have no androgenic effect and they do not antagonize the beneficial actions of estrogen as far as the lipidemia is concerned, the hyperlipidemia is concerned. Now we go on to see what is an anti-progestin, and this is a very important drug. It's called mifepristone. It's a progesterone antagonist, plus it has got partial agonistic activity, and it's also have anti-glucocorticoid actions, anti-glucocorticoid effects. What's the importance of mifepristone? It is a safe post-coital contragestational agent, and it is to be used within 24 to 48 hours of the sexual intercourse. So this is supposed to be the best management within 24 to 48 hours of sexual intercourse. If you want to have a contragestational effect, it's a safe post-coital contragestational agent. The next one, it can be used for termination of pregnancy up to 9 weeks of pregnancy. So it's got this abortifacient effect, and it's used in 600 milligram single oral dose. So mifepristone is really a promise amongst the anti-progestins. It's commonly used with misoprostol used by oral route or by intravaginal route of administration. Now I have brought something for you, and this is going to clarify your confusion about this chapter as far as the adverse effects are concerned. Which adverse effects are typical estrogenic, which ones are typical progestogenic, and which one are common to both are shown on this table. Please have a look at this table. Estrogens, thromboembolism, deep vein thrombosis and stroke, then migraine, gallstones and gallbladder disease. Then as far as the uterus is concerned, endometrial cancer, dysfunctional uterine bleeding and endometriosis. Then a characteristic adverse effect of nausea and epigastric distress and psychological disturbances. Coming to the progestins, there's acne, hirsutism, increase in the LDL, then skin pigmentation and elevated body temperature, and more susceptibility for breast cancer. They also produce esophageal reflux, and there can be mental depression. So these are the individual effects, adverse effects for estrogen and progestin. If you come to the common adverse effects, it becomes easy, and you don't have to pick up this estrogenic or progestogenic. Have a look at it. The common adverse effects to both the substances, both the components, is headache, engorgement of breast and mastalgia, diabetogenic effect, fluid retention, edema, weight gain, and raised blood pressure. In short, the effects on the breast, the headache, diabetes, and the whole cardiovascular system is common to the estrogen and progestins. So we went through estrogens, the selective estrogen receptor modulators, progestins, and one important anti-progestin that's called mifepristone. And I am sure I have tried to concise this particular chapter in such a way that your basic concepts are going to be clear, and it's going to be useful to solve the multiple choice questions as well as to make a concept in your mind and to read further and build up your own knowledge on estrogens and progestins. As far as contraception is concerned, we shall be discussing it on a separate session. I am sure it was brief and it was knowledgeable and you enjoyed the session. Thank you very much and best of luck.